We're going to get started in a minute, so please find your seats. And this is Transforming Mental Health Crisis Response. So hopefully you're here to learn about how we can have alternatives to police response to mental health crisis calls. Very important topic. Okay, welcome. So we'll get started. Hi, everyone. My name is Jordan Rosenthal. I use she, her pronouns, and I am the Director of Advocacy at Community Access and a proud steering committee member of Correct Crisis Intervention Today, CCIT-NYC, which is a coalition dedicated to transforming how New York City responds to mental health crisis calls. And today I'm here with a bunch of experts, who I also get to say are dear colleagues of mine, who will introduce themselves. So one by one, Evelyn.
Hi, my name is Evelyn Graham-Nyaasi. I am a peer, which is a person with lived experience. I'm also a steering committee member of Correct Crisis Intervention Today. I am on a coalition for Daniel's Law, and I'm a NAMI ambassador.
Thanks. Olivia.
Hi, can folks hear me in the back? Can you raise, okay, yes. Hi, Olivia Ensign, she, her, hers pronouns, and I'm a senior advocate and researcher with Human Rights Watch.
Hi there, I'm Beth Haroulis. I'm a senior staff attorney at the New York Civil Liberties Union. We're the New York State affiliate of the ACLU. I'm also a member of the CCIT steering committee. I'm on the CPR committee as well as the Daniel's Law coalition. So we are working hard here in the city.
Hi, everyone. Good afternoon. Thank you for joining us. I'm Sheina Banatte. I'm the Managing Director of Advocacy at Justice for Earth Peer Coalition, and also am a proud member, steering committee member of Correct Crisis Intervention Today.
Awesome. So we're going to start off with actually a temperature check. And I'm going to ask all of you some questions. And I would like to see a raise of hands if you identify with this. So please raise your hand if you've ever experienced a mental health crisis yourself. Okay. Now, raise your hand if you've ever witnessed a mental health crisis and didn't know what to do. A lot of us, okay. So what if I told you you didn't have to call 911? And there were alternatives that advocates were working on to create peer-led, non-police mental health crisis response systems in New York State. Is that something you'd be interested in as an alternative? Raise your hand if you'd be interested. Okay, so basically the whole room, thank you. So that's what we're here to talk about today. And I'm going to just give you a quick little overview of how this session's going to work because it's a little atypical. We're going to spend the first half hour having a little bit of a normal panel discussion. And then the second half hour, we have some questions that we want to ask all of you. And people can line up on the mic and respond. And we'll have a community discussion about kind of like, what has been your experience with police crisis response? What happened? What would you like to, can't word this right. What would you have wanted to happen instead, right? And other things of that topic. And then at the end, we'll have a generic Q&A where you can ask our panel and myself anything that you would like relevant to this. So let's get started, thanks. So let's just start first with Evelyn and then Sheina. Can you tell us what happens when police respond to a mental health crisis call?
Well, I can give you I can tell you what happened to me. I didn't even call the police. Someone in my home called 911 and told them that I had a knife. I did not have a knife. When I opened my door, there were 8 to 9 police officers in the hallway with guns. One of the officers told me I had to go with him, and I went downstairs because I was really afraid. I didn't know, what they were going to do. And I went downstairs, and they asked me, did I want to get into a police car or an ambulance? And I chose the ambulance because I didn't know what was going to happen. And they took me to Bellevue Hospital, dropped me off, and I was there over the weekend. My family didn't know where I was for 3 days. And they finally took me upstairs to the ward. and they didn't release me until 10 days later because I didn't know what my rights were. When police usually are called, normally you would expect them to ask you questions and find out what's going on, because you have family members that do very different things for whatever reason. They wanted to take your money, or they had an argument with you, or something like that. So in my situation, I would have felt that as a peer, that the police officers would listen. Yeah.
Thanks. And Evelyn, can I ask you a follow-up question? Did you feel like in this experience that you had a choice in what was happening?
No, I did not have a choice. One wrong move and that would have been it. So I would definitely have to follow through and do what they say. So no, I did not have a choice.
Thanks. So that brings us to Sheina, who, can you kind of elaborate on, what happens when police respond to a mental health crisis and the seriousness of what happens, if you don't listen?
Okay. So what happens when police respond to a person experiencing a mental health crisis? In my personal experience, the most extreme, unjust, inhumane, traumatizing, and heartbreaking outcome that can happen did. I lost a beloved member of my family and our community on December 20th, 2021. That's actually 30 months ago to this day. So to me, though, it feels like yesterday. Out of 20 individuals killed by NYPD in the last 9 years because officers are sent as responders to people experiencing mental health crisis, the 19th is my 26-year-old cousin, Pierre. He was another person of color, someone who mattered and who was valued and who had so much life to live. Was killed when police responded to what we believe was his cry for help, after he himself called 911 while he was in crisis. NYPD showed up with their uniforms and their hostility and their commands and callousness and their flashing lights and their tasers and their guns. They fired 10 shots at and now he's dead. He didn't get the help he needed because he was approached as a criminal instead of being cared for as a deserving human being. There was no de-escalation tactics used. There was no care. He was not provided the opportunity or the gift of recovering beyond that mental health episode.
Thanks, Sheina. And I appreciate you and Evelyn both sharing such vulnerable stories with our audience here today. It's really sheds light on how important this situation is. So this brings me to my next question for Olivia. So Olivia, what could have been different in both of these situations? And what are the, not best practices, but the good practices that are occurring across the country?
Yeah, thank you so much for that question. And I think we just heard really powerfully what happens when crisis response falls short, which is why it's so important that we talk about good practices and what can actually work in communities. In terms of a rights-respecting approach, what that looks like, it looks like centering consent. It looks like respecting the will and preferences of the person in question. It looks like meeting certain standards of quality, accessibility, and availability when it comes to services. And it also means recognizing that recovery looks different for different people and that people are not objects of rehabilitation. They need to be active experts in their own recovery. And what that requires is looking at people holistically and considering their needs. So that means considering housing status, disability status, employment status. It means considering structural discrimination and other forms of exclusion. And it means treating the person holistically and making sure we're moving beyond destabilization, or moving beyond stabilization, moving beyond even talking about crisis, and instead actually connecting people with the services that they need to thrive long-term in their communities. So that is what a good practice approach and a rights-respecting approach looks like. In terms of the trends that we're seeing across the United States, there are long-established alternative response programs that don't deploy a police officer as the primary or co-responder when someone is having a mental health crisis. But what we've seen in the last few years is really just a huge uptick in programs, whether at the local level, the state level, the county level. And a lot of this really accelerated after the killing of George Floyd and the ensuing conversations around alternatives to police. And of course, these programs need to be tailored to the specific communities that they're in, but this really is this exciting moment because there's so much energy around this to have cross-border conversations among advocates, among practitioners, among decision makers, to really share good practices and also look at implementation strategies. In terms of, to capture some of these trends, last year, Human Rights Watch, in partnership with New York Lawyers for the Public Interest, began a national scoping project. So we looked across the country at programs, alternative response programs that responded to people in crisis without police as the primary or the default responders. And we were able to find 160 of these programs across the country, all at every level, again, the county level, the local level, the state level. And many of these programs started since 2020, and we looked at things like operational framework, triage protocols, team makeup, funding sources, response times, outcomes, and basically documented as much as we could with the hopes that, again, we're going to be able to facilitate some information sharing. This research is still ongoing. We hope actually to publish in the next year or so with our findings. But I figured I'd just pull out a couple trends of what we've seen across the country. And some of those are, most of these programs tend to be concentrated in urban areas, but we've also seen a real increased momentum in rural areas, which is significant. These teams typically consist of 2 unarmed individuals, but this can look like a range of professions. It can be EMTs, it can be nurses, it can be peers, it can be mental health clinicians, social workers. The range really is notable. And notably, at least 36 of these programs formally incorporate the role of a peer into their responder team. These programs respond to a variety of calls. They tend to respond to nonviolent situations, but the definition of this can really vary across jurisdictions. And these programs provide a range of services, including on-site assessments, de-escalations, safety planning, crisis counseling, referrals to appropriate community services, and follow-up care. The funding structure, which I know is always of interest to folks, really varies across jurisdiction. Often it looks like a combination of local, state, county, and federal funds, and includes some private funds, including from foundations. And notably, while we've seen historic investments in these kinds of programs in the last few years, it's still really just a drop in the bucket when we consider it next to budgets for law enforcement and traditional policing. So those are some of the trends, and again, the theme here is really around momentum, it's around energy, and I think the hope is that one day these programs aren't even considered alternatives, they're just the first response, and there are robust funding structures and political will and community buy-in, so we can make sure that we have, again, these holistic, peer-led, community-based services, which include expanding and preserving affordable housing, especially supportive housing and housing with wraparound services. And I think I'll stop there.
Yeah, and I just realized that we as a group didn't define peer. So I wanted to stop for a second and just do another temperature check. And raise your hand if you think you know the definition of peer. Could be whatever your definition is. Just want to know, like, do you have a definition of peer? Okay. So when we're talking about a peer in this context, we're talking about a person with lived mental health experience. And sometimes when we're having this discussion, you'll hear peer support specialist versus peer, and there is a difference. So I know this is a little bit ahead of time, and I guess this will also transition to the next question for Beth about what's happening in New York State. But Beth, can you tell us about not only what's happening in New York State, but the efforts that advocates are making to expand the use of peers and what a peer is in mental health crisis response, and how that's a little bit different than just, a peer support specialist.
So we don't have 100 years to talk about this, but in New York State, similar to the trends that Olivia's described, we had an episode occur up in Rochester with a gentleman named Daniel Prude. Daniel Prude was visiting his family in Rochester. There was a call for assistance because there was some drug involvement, some mental health challenge. The police came, totally dehumanized him. It was all captured on body-worn cameras. He was put into a spit hood. He eventually died. The New York State Attorney General's office investigated it and determined that excited deliriums, which is a completely fabricated, bogus medical claim, caused the police department to behave the way they did with respect to Mr. Prude. But he became a rallying figure in New York State. New York State treats mental health crises as public safety events. This rests in a very long-standing stigma against people with mental health challenges, that they are always going to be a danger to safety. We know that the data indicates that people with mental health challenges themselves are more often the target of danger, crime, death, physical injury, forced treatment, and the like. But we have in New York State mental hygiene law provision that actually mandates law enforcement as the principal responders, because again, we consider a person in mental health crisis to be a public safety risk, not a public health problem that needs to be addressed by public health providers. So using the situation with Mr. Prude, with his families as very strong advocates for him, with the local elected officials, Senator Brooke, Harry Bronson, who's the assembly person, there has been an effort made in the New York State legislature, and I'm talking about New York State because New York City always is the dog that wags the tail in New York State when it comes to crisis response. We know NYPD calls people in crisis EDPs. It is one of the most pejorative terms you can ever hear. That casts the way the entire system responds to a person in crisis. They're just a set of numbers, initials, and they're going to be dangerous. So trying to elevate away from New York City, which has the biggest police force, in the country, which has always responded to people in crisis and has always effectively either executed people or subjected them to grievous physical harm and trauma. We have adopted what was based on the CAHOOTS model, so it's a little bit ahead of what Human Rights Watch and NILPI have done. But the theory is to treat crisis calls as public health events that require the same degree of care as a person who's suffering a heart attack. Someone in crisis should be responded to by a medical apparatus. So that involves peers. That involves community-based, community-led, community-identified responses to members of their community. So what is a peer when it comes to crisis response? There has been a debate about, are you a pure peer, a person with a mental health challenge? Or are you a family member of someone who has mental health challenges? The intent is for peer to be as broadly defined as possible so that you have the best possible minds, people with lived experiences, crafting a crisis response. Because Daniel's Law calls for a crisis response to be developed within the locale. It is actually based on the New York State ambulance law, which allows communities to marshal resources, identify who the responder should be, in order to keep it local, to prioritize the humanity of the person who is being served by this response system, and to keep the police as far away as possible. I mean, we basically, have always said at the ACLU, NYCLU, that it's very hard to train a police officer to respond to crisis, to respond to de-escalation. Their model is command and control. Police should be available. We know responders, whether they're people from the mental health profession whether they are people who are community-based providers, whether they are peers, oftentimes can find themselves in a situation where they feel there is a risk. But it is, under Daniel's Law, left to the responders who are not law enforcement to identify a need for law enforcement involvement. Basically, stand back, be activated by the responders. Do not take over the scene. Do not subject people to harm. Do not threaten to arrest people who are trying to help. And make sure people are not taken to a site for involuntary treatment. That involves, and Daniel's Law contemplates, a sort of wraparound continuum of services. We don't want every response to be a crisis response. There needs to be early intervention. There needs to be pre-crisis. There needs to be post-crisis stabilization. There needs to be a system that actually meets people where they are and helps them survive and thrive in our society. That involves supportive housing. And we know what is happening to supportive housing. We know what all of the sort of issues, particularly in city and in urban areas, with gentrification, with developers, with investment banks that take over housing stock. We know that the system is underfunded. It has been defunded for a very long time. What we run into, of course, is police who say they do not want to be the responders. You can talk to almost any police officer, any law enforcement organization. They do not want to be the first responders. State troopers, NYPD, local sheriffs, local law enforcement, police departments, they know they are not trained. They oftentimes know the people that they are visiting harm upon, and they don't want the involvement. But you cannot talk about defunding the police. It really is reallocation of resources where we as a community, as a construct, have to figure out where do we want to put our resources. There's heavy competition for non-inpatient forced treatment for people. There is not a medication that is a silver bullet. You really do need a community. It needs to start early. There have to be safe spaces. And, again, Daniel's Law is not a panacea, but it is a model that imbues all of those concepts, all of those respect for human rights, and funding of appropriate response. It has to be linguistically competent. It has to be culturally competent. You have to overcome stigma that just is visited upon people because you can't move away from the stigma. And there has to be a really robust menu of options to assist people in the community. So with Daniel's Law, the state has refused to move this law forward, even though, there are enormous numbers of sponsors. What Governor Hochul did in the last, not this year's budget, in the prior budget, was to dedicate a very small amount of money to something called the Daniel's Law Task Force, which has been conducting listening tours around the state. They have been doing public hearings. They have been hearing from Gerstein Center, from Human Rights Watch. They are also going to be hearing shortly from Be Heard, which is the New York City.
You're going into the next question.
Okay, I won't go there. I won't go there. But in any event, the Daniel's Law Task Force is coming to the end of their listening tours, and they are supposed to be coming up with the menu of alternative programs that exist, that Human Rights Watch, NILPI, that the country have put together over the past couple of years. We have to overcome the theory that New York City and New York State are different. We are not exceptional. Our people who have crises, our responders, our systems are no different in New York than they are in LA, than they are in rural Iowa, than they are in Toronto, Canada, in Chicago. I think the principles are all the same. So the Daniel's Law Task Force is going to be next identifying funding streams, which we also know is a little bit of kabuki. There are surveys, though, that have gone out, and I think the CCIT-NYC QR code that
Yes.
Jordan was speaking to contains links to people to answer survey questions from the funding consultant to the New York State Task Force, asking about what people would like to see in terms of response to people in crisis. Are you an organization? Are you an individual who has experienced a crisis? Are you a person who has supported someone through crisis? So I urge people to access that SurveyMonkey link.
We'll send it around.
It's probably about a 7-minute set of information gathering. It is critical so that New York State understands that it's not just people like me, like our peers, our advocates, our providers. It is the state as a whole calling for a different approach to people in crisis that is health-informed, community-based, peer-driven, and meaningful and successful. So I'll stop there because I could just go on.
Thanks, Beth. So I know this isn't the exact question for our next two, but I'm going to split this and give you guys a heads up. I think you can both answer it, though. Evelyn, can you talk a little bit about what currently exists in New York City? And then Sheina, can you talk about, what do we want to exist instead?
Hi, how many people have heard of Be Heard? Raise your hand. Okay. Be Heard is, acronyms are Behavioral Health Emergency Assistance Response Division. Now, while the police officers are the first ones to show up, they are not the ones who really want to be there. With the Be Heard, they have a team of two EMTs, and one social worker. The problem with that, with Be Heard, is that you cannot request them when you dial 911. The police show up first. Then they have to decide if they're going to allow the social worker and the two EMTs to do what they need to do to make the individual feel at home or, a little bit more relaxed. Unfortunately, for me, I don't think that it's a good idea for police to show up because anything can happen. They're not trained properly. They are trained to respond, but they get 5 months of safety training, and then they get maybe a week or 4 weeks of mental health training. So that can be a problem. So with Be Heard, it's not really working the way it should be right now, and they don't have peers on the team, which are people with lived experience. I'm a graduate of Howie to Harp, which is a peer specialist training program, and we are trained to deal with peers who also have mental illness. So yeah, that's what's going on with Be Heard. We need peers on the team. Maybe you guys can help us get it. That would be great. But yeah, we need peers on the Be Heard team. And yes, officers are being trained, but they really don't belong there.
So just for summary, before I hand it off to Sheina, so Be Heard is supposed to be a non-police crisis response, right?
Yes. Sorry.
And the way that it currently operates is very limited in scope. So it only operates in select police precincts throughout the city. It's only 16 hours a day. You cannot request it. There's the social worker and the EMT, and I'm gonna be real here and out myself. I am a social worker, and I'm saying this as a white woman also, as a white woman from Long Island, even as a social worker, what do I know about someone having a mental health crisis in the South Bronx? We need to have someone with lived experience who understands those unique situations that person is dealing with, instead of just here, let's throw some acronyms and some quote-unquote expertise to relieve the situations, right? So with that, I'm going to hand it off to Sheina to talk a little bit about, what could happen? What do we want instead?
Yep. Thank you, Jordan. And yes, just emphasis on the peers is just so significant and so important because they are culturally responsive, they're trauma informed, they allow the person in crisis to be seen and heard and validated, and really in essence to keep living and breathing beyond crisis, which a lot of times if law enforcement are the one that continue to respond, that doesn't happen. What we envision is for a peer-led crisis response team, which will operate 24/7. It'll be citywide. Again, they'll be well-trained with EMTs. They're unaffiliated with FDNY or NYPD. It's a coordinated crisis response system. Will include prevention, alternatives to hospitals, and robust follow-up from local service providers to avoid future crises. So it's really important as possible. I don't know if I should talk about the hearing we have next week. Now,
well, I think we can talk about that a little bit later. But
Okay.
yeah,
Yes.
we can get. Well, I guess people are kind of curious now too. I hate when we do. Or like I always do this where I'm like, do we talk about this? Do we? So part of what we're here today, before we go to this next portion, is all of us on this panel have been really strong advocates for non-police mental health crisis response in New York City. And there's this program, Be Heard, that we were talking about. And Be Heard has basically been able to operate without any critique or anything. And what we want and what we've been able to accomplish is to have an oversight hearing, which is happening in City Council next Wednesday, the 26th. And this is a really big deal because it required 4 different committees to come together and say, we want to have this hearing. And it's going to be about Be Heard and non-police crisis response. So we really encourage all of you to use that QR code so we can send you the information, not only about the rally, but with our testimony template. So you can have very limited work to just say, I want peers, not police, and kind of what that looks like, and also highlighting the issues with Be Heard. Yeah.
I just wanted to say that CCIT had advocated for a non-police response and under Mayor de Blasio, and the first thing, he didn't do it. He gave us a co-police response, and then Be Heard was supposed to be a non-police response. So we are grateful as a CCIT that, they at least have a non-police program, but we would like for them to incorporate peers on it.
100%. That was really well said. Does anyone else have anything to add just before we, before we go to our interactive portion? Yeah.
One thing I wanted people to be aware of, it really is an alphabet soup down here in the city. So for people who are in the city, you do know probably that the 988 number, which was intended to take away a police response to people in crisis, is actually operated and feeds straight into the 911 system. So there's a lot of work that needs to be done at 988 with training the dispatchers to assure that people are not immediately put into 911 EDP, response mode. Also, if you call 311, there's been reporting about this as well, where people call 311 specifically to avoid police responding in New York City to their family members or neighbors. That also, the 311 operators, remember the entire dispatch system in New York City is operated by the NYPD with an assist from the fire department. For people who were here during September 11th, you may recall they didn't talk to each other. Their systems really have not improved that much. There are other teams who are operating in the subway systems who are separate from the NYPD, the SOS teams that actually have a piece of NYPD, but the MTA police are involved as well, and they operate under the auspices of the New York State Office of Mental Health. So there are a lot of players here, which creates an enormous amount of confusion, which at the end of the day drives the police response because they come and take control of the scene and decide who gets to do what. So I think it really, in terms of what the city council is doing, the fact that there are multiple committees is that they are themselves siloed into particular city agencies, and they don't see the need for a coordinated system here. There is a lawsuit that has been brought by a number of my colleagues challenging the way New York City has determined to treat mental health crisis responses as a policing response. The city charter designates New York City Department of Health and Mental Hygiene to be the lead, and the city has delegated that to the NYPD. So there are a lot of different moving pieces, which makes it really hard, I think, for providers, for families, for non-English speaking communities to understand how to navigate a system that at the end of the day will visit trauma on their family member, their loved one, themselves, and the community writ large. It also takes away enormous amounts of resources. So again, we'll be testifying obviously in front of the City Council. This is a very, I think, sort of turning point moment in the city because there is a lot of dispute around the strength of the council versus the strength of the mayor. And it really is a proxy battle for funding to the police in New York City. So I do urge people, if you can, because I know with a lot of C4s, C3s, there are a lot of lobbying issues that present, but I think making sure that the council people understand the strength of the voices, the strength of the advocacy, to get to the people who are actually impacted here, because they turn everything into money in New York City, and this is about people and people's lives, and strength and vitality of communities. So please testify.
Yeah. And like I said, we literally wrote a testimony template for you that even has parts that are like, insert your lived experience here. Talk about if you've ever experienced coercion here. So, and you can definitely use that tool.
Can I add something, Jordan?
Yeah, of course, Sheina.
Thank you. Just from my personal experience, again, with my cousin, like some people might still wonder, well, why can't we just train the police? Like, we can't. Police can't be trained. It's like in their culture, again, just to approach, the mentally ill as criminals for some reason instead of the public health issue that it is. When the police encountered Erd in the subway and immediately labeled him EDP, emotionally disturbed person, they still didn't provide him the care and the help that he needed. They tased him, they, shouted commands at him, they killed him. So that's why we really, really need to just incorporate peers. There's even with Win Rosario, it said that those officers were trained, and still they came in. There was a language barrier that, again, peers provide a great opportunity that police don't. So even when people say, well, maybe police officers can be trained, they can't. We really need to incorporate the peers, the people with lived experience who are well trained and who are willing to just keep working with that person to make sure that they get the help they need, and to just the aftercare, the continuum of services that we're talking about.
Yeah. Olivia, do you want to add something?
Let's applaud that first. I mean, just to add, the national research on this really backs this up. If we look at CIT training for police departments across the country, there has not been a net effect that has been documented. And in fact, looking at Chicago's police department, for example, officers that were trained in CIT were actually more likely to use force than those that were not. So again, the research nationally backs this up.
So now we want to kind of hear about your experiences. We have a bunch of questions, and I kind of will, say one, and then a few people can come up to the mic and answer, and then we might say some more type of thing. And then at 2:30, 2:35, we'll do general questions. So we wanted to know from all of you, have you ever been in a situation where you had to use 911 for a mental health crisis? What was that like? And what were the impacts on your wider community? And feel free to come up to the mic so just everyone can hear you, because this session is being recorded. So that way, other people who are not here can hear about the wisdom that y'all have.
Okay. Hey, I took my name badge off, but I'm Christian.
Hi, Christian.
I'm a program director for a MICA shelter that runs under OMH here in New York City. And escalation occurs. People get emotional. People have that. it's understandable. Look at the system that we're living in, and look at the system that people are living in. It's by itself inhumane and undignified, and it already strips people of their basic autonomy as well as that humanity and dignity, and there's no trauma-informed care. So I've been trying to work with to protect, because we also have DHS police in the building, to work with my staff to triage a new formed EMS protocol that aligns within the ability that I have to work with my clients and my staff to triage that on the scene without calling downstairs before, to bring them up because of the traumatization, because of the command and control, as you said. I think that's a really good summation, and that's a really great way to put it. And, when you have 3 dorms of people that are living there, but 10 by 10 by 10, every 30 person, plus my 17 staff, so all 47 people are affected in addition to the other folks on site. This needs a radical overhaul. And one of the things that I have dropped from my protocol is, if you have to, before even going near the term EDP, is to consult and to go back to the protocol that is constantly a work in progress. And I don't know what else I can do, because invariably they come in and they come upstairs. And then we're actually de-escalating the EMTs, and we're de-escalating the police officers, more so than the client that just needs a minute.
Yeah.
Just needs a
Can you
minute to get
highlight
it out.
the EMT part? Because that's really interesting and something that we've all noticed here, but I don't think a lot of people in the audience may know about how EMTs play into maybe the revving up of a situation.
Yeah, they basically come in and they're under the same sort of command and control auspices, and they're there with the pretenses. They're rolling in a bus, and they're coming in with their stretchers and all their little bags of everything, and it looks like they're there to quote unquote be in the caring profession, but they're actually not. I see them more as police. And then what I then have, and what my staff has to work with, is that we have the fallout of that re-traumatization and that re-triggerization that occurs 46 times and then some, over and over again. So then OMH is wondering, and then everybody else is wondering, well, why didn't we get to that email? Or why didn't we get to that other thing? Because we're de-escalating everyone. So I'm just curious. I'd like to flip the question and see what other folks do in this system and in this industry to sort of support and create those supports for the individuals that we are in this caring profession for. Just curious.
That's a great thing. Thank you so much. Does anyone on the panel have any response to that before we see if anyone else has anything?
Just kudos to you, though,
Yeah.
for your care and for, because just seems like mentally, especially, there's so much stigma, around, and it's become such a fearful situation to approach someone in the mental health while they're in crisis. And meanwhile, you're trying to control all entities and stuff, and still you manage to keep the person in crisis, your main focus. So just kudos to you. Yeah.
Honestly, from there, it's just about utilizing my privileges to escalate that, not escalate, but I'm sorry,
Right.
to elevate that in my title, to elevate that to a position to really, that's where my title really does come in to play. Because if everybody knows, and there's always been pushback by folks on site who come into site thinking that they can take over.
Yeah.
But I very firmly remind them that quiet power doesn't come with violence. And that when they're on my site, they're on my unit, they're with my staff, they're with my clients, even if they have to leave the site, that they have to deal with me.
Thank you for doing that, because, we litigated against H&H for years out of Kings County to try to get that model in the muscle memory of all the staff on site. I mean, at the end of the day, for,
Can you talk more
for the state folks, for the city folks, what you're describing in terms of, just the day-to-day in a congregate setting, that is part of, culturally competent, trauma-informed care that is never factored into the folks who fund the people who set the systems up. I mean, exactly, it's not just one person who's being escalated. It is everyone. There is collateral consequences to everyone. You see it in congregate settings. You see it in communities. You see it in families. Generations of trauma that isn't recognized. And so trying to amplify that, to a best practice, I'm not sure how you do it. I mean, I use blunt instruments because I litigate, but, it's really, really important to speak that truth to people and to ensure that the people who run the systems understand.
And I just want to know other resources for how to further ensure that this is like a good practice and that it still centers the individual.
Yeah. So I see that someone has their hand up. Feel free to come up to the mic, sir.
That's hot mic.
Okay, one of the things, I'm the director of supporting housing program for Black veterans, so I deal mainly with veterans who have mental disability.
Can you please speak into the mic?
I mainly deal with veterans that have mental disability. One of the issues I find is more of the preventative pieces being in place before the police are called, whether it's adult protection services, whether it's mobile crisis. Get in contact with them in a timely manner to help assist in the matter before you have to call.
Yep.
I never call the police. I always call EMT just because I know through experience what that may look like. But it's the preventative piece that often not talked about how can you call someone and they guarantee show up with a team to help escalate these matters without the police being involved in the first place. And that is what is kind of missing, because you can't call anyone. I tried calling adult protection state. It takes 3 days to get there. I tried to call other sources, and it's never there. So by the time they do arrive, the matter have blown up so much. You kind of like, what do I do?
So this is why everyone needs to testify next week, because Be Heard is supposed to be an emergency crisis response system, which means that it should only take 10 minutes for them to show up. I'm being serious. That's not what happens, but it's what's supposed to happen. In reality, it takes about 20 minutes, okay? So still faster, but part of the problem is they only answer 3 to 5 calls a day. So what we're talking about when we're talking about adding peers to teams and stuff is how can we also make this a broader program to serve more people, so to have that preventative piece. But similarly, and I'm sorry, I don't mean to speak for all of our panelists and stuff, I get very passionate about this, obviously. For the preventative piece is also investing in city resources that are things like clubhouses, like crisis stabilization centers, like crisis respite centers, right? Things that really elevate choice, that allow people to define what they need for their recovery instead of a patriarchal, militarized response that is also rooted in white supremacy.
Well said. Well said. My name is Sandra. I'm a clinical care manager. One of the things for me, I could only talk about my practice, and it really has helped me. Usually contacting the police for me has always been the last option. I think we have to go back to personal style and knowing some of our bias when we approach a certain client. Even if the person has mental health challenges or they're in crisis, most time they have some level of insight of what it is that they want, how it is, what help that they want, how can you get that work done? So I think it's getting this client involved in the planning. I've had clients that said, Miss Sandra, do not call the police. Maybe you and I can go to the ER site together. And that is empowerment. Okay, let's do that. What else can we do? I think it goes back to being very cognizant that the person who's experiencing the crisis, they are still human. And I always go back to Maya Angelou. They may not remember what you said, but they'll remember how you make them feel. Yes. They are so alert. They see the nonverbal cue. They see it. So again, I think we have to be very cognizant. We gotta shake things up, but it starts with us. That's when we're gonna see real change.
Thank you. Come on up. Come on up. We have room for everyone. Come and ask your questions or say your statements.
So I heard the gentleman from the floor and what he mentioned about calling the police. I think the issue here is that we all know our clients. If you know your clients individually, you know who to call the police and who not to call the police. I had a client who had come to the office one day, shoved the security aside, broke the door because he was looking for the program director to kill him. What type of peer support you think can address this issue? No. He's been very, very violent. The only people we have to call are the cops. All right? However, when we come to individual tenants, a few days ago, we were trying to set our goals for the year. And one of the goals I set for myself is to know the tenants, to reassess all the tenants in my program individually. I'm not going to make them come to the office. I'll go to them to find out where they are and where they are going. Yep. In this sense, if a client is experiencing any type of crisis, I know how best to intervene. Yep. Now, it looks like we all try to probably paint the police as the bad guys, but I do know some of them are really good. A few weeks ago, we had a crisis on a job, and we invited the police in. And the intervention just blew me away. I was standing back, and the police officer engaged this client to the extent where I'm saying to myself, you must be a social worker because you are doing a great job. Calm this guy down until the ambulance arrived. Yep. So in a way, I think that it's best to know your tenants and see who to call the police and who not to. Whichever way it is, we're going to have the law enforcement involved one way or the other at certain times. Right. So we should be aware at what time do we involve the peers? Who are they? What crisis is this person going through? What support does he need? Is it violent? Is it a calm person? Is he hearing voices? All this come to play whenever we do intervention. So I would suggest that we tend to know our clients better, so that way the intervention to be tailored to the individual clients than, one size fits all. Thank you.
Exactly.
Thank you.
Yeah.
I think there's some
wanted to say
responses from the
something.
panel.
We're not saying that the police are bad, or we don't want them at all. If it's a situation where, like you describe a weapon a real weapon, not a butter knife, then, you call the police. But other than that, we're not saying that the police officers are bad. What we're saying is that they don't belong there, and they don't want to be there.
And also, sorry, Beth. Also is just the peers. Peers should determine if police should be involved. I think that's an important thing too. Like, yes, I definitely agree, and thank you for speaking about that, about how definitely it's not a one-size-fit-all, and how you have to meet everyone, where they are at specifically. But we just have to be careful with saying yes, police are. You just don't know, what officers are willing to de-escalate and who really can't, and just most of them just can't. So I just think if peers are there and they made that determination, like, okay, maybe police can be involved, then I think it's a better outcome than just hoping that an officer shows up and is able to help the person in crisis.
Yeah, once upon a time when we were trying to see if crisis intervention training would work for law enforcement, we had been advocating, as many other folks were, that members of law enforcement self-identify for the training. What NYPD does is to train the entire force badly on de-escalation skills. There are definitely people on the force who you would want to appear, right? Because they know how to de-escalate. They know how to take a situation down. No one gets hurt, including themselves. But what we see, are the body-worn cameras where there's escalation. In terms of knowing clients, knowing people that you work with, serve, we've also been trying in New York State to get, people have, a health proxy. If I'm in the hospital, I don't want this. I don't want to be put on a machine. I don't want X, Y, and Z. We have been trying since Kendra's Law was enacted, and I was a baby then, but in 1994, we were advocating for mental health care proxies, which also permit a person a piece of empowerment to identify things that they want to have done, not want to have done, people they want to contact, places they might feel safe. That is something that New York State has been very loath to adopt, but again, it's sort of part of a public health model where you empower a person by letting them have a statement that can be shown to anyone, including law enforcement, as to what they would like to see or have done to them in a situation where they are deemed not capable of making decisions. And that is something that we really need to move up on.
And
Yeah, Olivia, and then we'll go back to the audience.
just to quickly add, this is also where investments in prevention and investments in continuum of care are so important, because the idea is hopefully people are not even at the point of crisis. And so, again, it needs to be investments from all sides.
In the community.
Yeah.
Thanks, everyone. Next.
Good evening, everyone. My name is Sheina Boddington. I'm a nurse for one of the Breaking Ground locations, and I actually dealt with my first crisis on Tuesday.
Wow.
Staff came to me and said that we had a client that was pretty manic, and they wanted me to come and see what was going on. It seemed that she ran out of her medication about last week Thursday, so now she was having episodes. We tried and we tried, so as a team, we said, okay, we're going to call EMT. Thinking EMT would come, the first to show up was the police. They were very standoffish. They tried to talk to her, but then after a while, they just stopped. When EMT came, EMT was slightly aggressive too. Next thing I know, she was being handcuffed with no pants on, her arm being bent behind her back. So now in my head, I'm like, oh my God, as the nurse, look what I just did, or look what I... So now I felt even worse. Now I'm running through the building trying to get her pants. They're trying to bring her out the building with no pants on. It was a mess. I'm thankful that I came to this training today, so now I know Pierre's is who I go to, because it was ridiculous. I felt horrible. And to see that, you know, she didn't do anything. I mean, yes, she didn't want to go, but she wasn't aggressive. She wasn't violent. You know, I think that they could have done a little bit more as opposed to just picking her up and bending her arm behind her back. So thank you guys for the information, and if anything else you can give us, please.
You can contribute. You can write a letter. I mean, what is that we have to do? Written testimony.
The testimony template. Yeah.
You can fill it out and send it in so that they'll understand. And yours is brand new, so
Yeah.
it will really make a good impact.
And you can write in the section too, like about how this traumatizes more than just the person in crisis, right?
Yeah.
Like now you have to deal with
Right.
that as well. And you're supporting people in your role at your job, and you're sitting there with this heaviness,
Yeah.
right? And that takes an impact on your service delivery. So thank you so much. And, I would say to everyone who's here, Pierre's not police.
Yes.
Thank you guys for everything.
Hi, my statement is just very simple and brief. Oftentimes when anyone sees a police officer, whether they're in crisis or not, just the sight of the uniform can be triggering.
Yep.
No matter how helpful or well-trained that police officer may be, especially for someone in crisis, just seeing that person in uniform may not be helpful. When we see a police officer, many of us comply, calm down, et cetera, but that does not mean that the crisis has been resolved.
Amen.
Yep.
So just to speak to that, in terms of one of the good practices that we've seen in models across the country, part of it is minimizing the power imbalances. So when a responder goes out, it may include not wearing a uniform, not wearing a badge, because it's not just
flashing
police
lights.
uniforms that can really trigger and cause folks to deteriorate. So just to add that piece.
Yeah. Thanks for that, Olivia.
Good afternoon, everybody. My name is Derwin English. I'm a program director for services for the underserved. Right, so I wanted to just take the opportunity to just branch off of something that he asked. Something that our organization does in order to capture our tenants' voice when they're mentally stable is when they're coming into the program, we use something called Mary Ellen Copeland's RAP assessment, which kind of is like a voice, the tenant's voice, when they're not able to advocate for what they would like for themselves. We are able to get that information once they're getting in. You can kind of like follow up and do what they would like to be done.
Thanks for that. There's also advanced psychiatric directives, if anyone has ever heard of that. I believe that's actually a different, Joelle, is that a different, is anyone here talking about that today? Yeah, it already happened. Oh, it already happened. Yeah, so offshoot, if you're interested, like Joelle said, there's something about advanced psychiatric directives, which is basically what Beth was saying before, which is like having health directives, but mental health directives. And yeah, thanks.
Good afternoon, everyone. My name is Daisy Rice. I'm the program director at the Doe Fund. I have a client that has a severe mental illness. He is resistant to any treatment. He really doesn't believe that he has a mental illness. He's torn up his unit several times. We fixed it back up. Is uninhabitable again. He bangs. He threatens other residents that live in the building. He threatened to take the head off of someone and eat it. There's several things. So I called in mobile crisis. I've tried CRT, crisis response team. They come out. By the time they come out, he's settled back down. He presents well. The police and the social worker walk off, and by the nighttime, he's doing the same thing. I've called the police out several times. They've been called so many times for him because he's so violent, and then he presents so well. They walk off, they leave him. The apartment is down to like the installation in the walls. It's like a horror scene, truly. I finally got, by pleading, mobile crisis unit to give me a mental hygiene warrant to take down to the courts to ask for this. I went down to the courts on Friday. The judge gave me the mental hygiene warrant, saying that he killed, by the way, he killed his dog in the hallway, slammed it against the wall. We had video of this, and still we got no response from anyone. I don't think that he needs jail time. I think he needs to be mandated to a program where, whether it's medication monitoring, something needs to happen before something tragic happens, and then the cameras are on and we're saying, what did we do? So with that mental health warrant, I am still waiting to this day for the sheriff to come out to get this guy so that we can go back to court. But I think the reason why I got up here is because that is my last resort. I would like to plead to the judge to say, listen, we need to get him into a program where there's medication monitoring. We can't send him back to the apartment because it's uninhabitable for him to live there. And then I'm asking for my funders to give me a TSRO to get him into, if I can't get him into the psychiatric treatment. So I think the reason why I'm up here is some feedback. What else can I do before something tragic happens, either to him, being killed by the police, or someone in the building that has sleep deprivation and they're tired of listening to the banging at 2 and 3 o'clock in the morning. And by the way, he has no door. He tore the front door off of him. So anybody can just walk in and kill him in the middle of the night because they're so stressed out. I have a petition from the residents in the building saying we can no longer deal with this. So I'm just asking, what else can be in place? Because at this point, I'm at my worst end, and I've tried everything, and I really think that this guy needs help. And it's every door that I open, it's a brick wall. It's oh, well, if he doesn't want to go, we can't make him go. So where do you go from there, where a person is not even in touch with the reality that they even have this mental illness?
So, speaking as somebody from the ACLU, there is a continuum of need, right? You look at each person individually. What we have is somebody like this gentleman who clearly requires some sort of intensive level of intervention to work with him to figure out what might work, right? And how he can himself live his best life, right? And not be visiting harm because he's harm to self and others, right?
Right.
The system is set up so that, this is what gets reported on. And everyone who has a mental illness acts like this, which means everybody is an EDP, which means police, right? So there are people who have severe, persistent mental illness that the system, and again, to Jordan's point about a system, it's founded on white supremacy control issues. He has to be met where he is. And so you are trying to, find something. You have this excuse that you can't compel anybody into anything. I mean, it sounds, and I'm just a lawyer person, but it sounds as if he meets the standards for a more intrusive intervention at this time. And the question is, how do you go about doing that? There's a mental health court, but he doesn't have criminal justice involvement.
Right.
They do have a process in the city where you can petition for a Kendra's order, basically, but you have to
We don't like
demonstrate
it, yeah.
medication noncompliance, treatment noncompliance. So the question is, how do you get him into service so that you can sort out who is he, where should he be going?
Right.
How does he survive, and how does everyone survive, right? Because at the end of the day, he becomes the poster boy for why the system is broken and
Right.
everyone
Yeah.
needs involuntary treatment. So, maybe there's a way to get into,
Please.
what used to be New York City Well, through the Mayor's Office of Community Mental Health, Brian Stetton. We can give you Brian Stetton's contact information because he is one of the mayor's advisors, right, on severe mental illness. Because again, when a system does not, in fact, address people who do have needs at that level, the system is really broken, and it becomes the excuse. So, he needs something, and I know you're beating your head against the wall
and
trying
I
to figure it
also
out.
did like the OMH high risk
Yep.
application. I did that as well. I have not heard back for that. So it's like I'm really at my worst end trying to get this guy the treatment that he needs. But thank you, I appreciate it.
Yeah.
Thank you for sharing.
Hi, my name is Lauren. I'm an assistant program director for a scattered site housing program at Canva, and I wanted to also back off of, we've also gone to mental health court, gotten warrants. We go, client gets brought in, client presents well to the judge, and they're like, have a nice day, go home. And we know, like, we're the ones that are going into these apartments. We're dealing with them on a daily basis. A few weeks back, I did have a client in crisis. We had, somewhat thankfully, the Be Heard team did show up. No police did show up.
Can we talk about this
Yes.
separately offline? I don't know, and I only know one person who's had a Be Heard response, and I have so many questions, which is part of the problem.
And so in the moment, it was like, oh, wow, like, there's no police. Like, this is the Be Heard team. I've heard great things. And it's a person, and let me explain this. I am also a social worker. I'm an LCSW. And they're calling their director, who's not on site, to make the assessment on whether or not this person needs to be taken to the hospital.
Oh my God.
And then even so, they are not transporting to the hospital. They call another ambulance to come and transport to the hospital. So now nobody who has had really direct contact with the client or witnessed their living conditions are going in and are now treating and saying this is why they need to be evaluated. This is why they need to be assessed. And if anybody has had any success with a mobile crisis unit, please tell me. I'm just saying I've called mobile crisis ad nauseum.
Yeah.
And they just, pre-pandemic, I can say it was a little bit different. But now post-pandemic, we call, and the first question is, are they a danger to themselves or others? And, and then a lot of times I can say directly that I have gotten into heated discussions with the coordinators saying, are you going to go out or not? Because why am I having to convince you that this person needs services? And even when they go out, you know, it's 3 attempts.
Yeah.
There's no assessment.
Right.
And there's no treatment. And so we're at a loss.
Please testify. Please. Here's my card.
And that,
please
that
email
might
me.
be, you know,
In your written testimony.
that might be, you know, sort of an outreach to the SOS teams and to OMH, because one of the things that we've seen in terms of what the legislative approach is, you know, they do want someone who appears at the hospital or in the court proceeding who is able to testify about what is the danger to self or others. There really is, and again, you know, the system is set up to do a Band-Aid response that doesn't actually solve anybody's problems, right? And doesn't get a person appropriate services and treatment. So no one sees them. You hear about the revolving door, the frequent flyers, right? That is a serious, serious flaw, because it is a system that is not set up to actually assess people, to ensure that they get what they need, because guess what? We don't have enough of that to go around. So if you identify it, then you have to give it to them. And if you don't have it, so you don't identify it. I mean, it is just, you know, we could go into deinstitutionalization and defunding and all of that, but continuing to ensure that people actually, a statement maybe from staff that, you know, is brought into a facility, you know, give it to MHLS, Mental Hygiene Legal Services, so that they understand what is going on in this person's life, because everyone presents well. And you know, and courts like that, frankly, because you know, I'm respecting their rights. And I'm the first one to say you need to respect rights. But, you know, if you're respecting rights in a kabuki fashion because you do not have the facts and you don't want to know the facts, then that makes the system fail. And then the funders can say, it doesn't work, put everybody away. So.
And Rikers is the largest mental health provider in New York City, if you didn't know that already. So just a unfun fact.
Good afternoon. My name is Ariani. I'm a clinical program manager for 2 SROs for Canva. And my shelter system is basically the clients go to HRA, they get a referral, they come to us with that slip. They come with no history or anything. So when we do the intake, the client, it's saying that they have no mental health diagnosis whatsoever, but meanwhile, they're responding to internal stimuli. So a day have passed by, 2 days, they have no connection to mental health. They start destroying the property, the smoke detector, the fire panel. So I always try to give them the benefit of the doubt to see if they can connect with me, because with people with mental illness, you know, they need to connect with someone. They need to find that close space. And usually in my office, what I do is I keep a little bucket with coping skills tools. So that is like my way of connecting with the client. So I like 911 is always my last resort. So usually when I'm having that one-on-one section with them, I try to encourage them to connect, because at the end of the day, they have to agree. And most of the times they do agree, but when they don't, that's when I'll do mobile crisis referrals. When mobile crisis comes on site and the client say, I don't want to meet with you, I decline the services, they don't come back. And that's the problem that I'm having. So then, in order for me to request room closure, mind you, these clients, it's a revolving door. The room got closed out somewhere else before coming to me. So it's not solving the problem, closing the room out, you know, because they're gonna experience the same symptoms anywhere they go. So connecting them to mental health provider, it's very draining when they don't want the help. They don't acknowledge the illness, and they don't acknowledge that they need help. So, you know, incident report after incident report, I do go above and beyond. Like if I have to go in front of a judge and say, I need a mental health warrant, okay, I get my form, but guess what? They don't call me a month later to execute the form. By the time they call, the client's not even in my premises anymore. So that's another issue that I'm having. And we really don't know what to do at this point. we need more resources. Like, for example, like I don't have a database like hospitals do where they can have the full history of the client, because when they come to the SRO, they come with a blank slate. I'm starting fresh, so I'm gonna tell you a new story. So we need something. We need more communication between their history and the housing facility receiving them. So like that, we can know what triggers you and how we can better assist you.
Thank you.